You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hey everybody, welcome to another episode of CRST, the podcast. I'm Christos Ifantidis, an anterior segment surgeon who's been lucky enough to train in New York City, Philadelphia, and on 4 different continents thanks to the Wills Eye Hospital Global Ophthalmology Fellowship. It really opened my eyes to how different surgeons address surgical planning, which is why this topic is so near and dear to my heart. I recently transitioned from academic practice at the University of Colorado in Denver Health to private practice, and I'm now at Tyson Eye in Cape Coral, Florida. I'll be your host for today's episode, and I'm super excited about our topic. We're going to be discussing preferred techniques for cracking the nucleus. It's the cover focus of the October issue of CRST, and I was honored to highlight 4 of the strategies I favor for efficient fragmentation of the issue. But I'm most excited about diving into today's discussion with 2 of my fellow contributors and all-around favorite people, Jeff Petty and Deborah Ristvet. Jeff and Deb, welcome. Let's start with some introductions. Jeff, why don't you go ahead and introduce yourself to the audience and tell them a little bit about the man and the legend.
Yeah, I'll find out who to talk about as far as legend goes. Christos, thank you, CRST. It's an honor. I'm Jeff Petty. I'm Salt Lake City, Utah. I've been at the Moran Eye Center from the start of my residency through International Global Fellowship and now as program director and continuing to work in the global realm. I love this topic. Teaching residents, you never really get stuck in one particular technique. Between vertical chop, horizontal chop, they really are greedy and they want to learn it all, and that's fantastic. And today we'll discuss a couple of phaco sparing, at least disassembly techniques from my article. And again, honored to be here and excited to learn more from you and Deb.
Awesome. Deb, why don't you introduce yourself and we'll get started after that.
Hi, everyone. I'm Deb Ristvet. I'm a 3rd-generation ophthalmologist from Alexandria, Minnesota, part of Vance Thompson Vision. And I am so thankful to be here today with 2 of my favorite people who I've learned through the years from, and I continue to learn. And that's what's so fun about cataract surgery. It never gets boring, right? As surgeons, we constantly learn and grow in our preferred techniques. And that's what's so exciting, is being able to really bounce off each other's ideas to give the patients the best result. So I can't wait to get started.
Yeah, that's a great point. There's not just one way, and that's what I think we're going to talk about today. But just as a little fun fact, 3rd generation, Deb's grandfather actually was one of the pioneers and mentor of and real just hero of mine who worked in Sierra Leone, who I really looked up to and still do. So, anyway, let's jump right in. So, with this October issue talking about fragmentation techniques of the nucleus, as Jeff pointed out, trying to spare phaco energy. So I think we can all agree that phacoemulsification has revolutionized cataract surgery. The issue is that dense cataracts and poor corneal endothelial function can make phacoemulsification not as effective, can cause patients some issues after surgery. And so cracking the nucleus in different ways really comes to the forefront for us. As patient advocates and surgical educators, it's our responsibility to be as exposed to as many techniques as possible so we can find out what feels most natural for us, and then we can share it with everybody that we teach, residents, fellows, and other colleagues. So just to touch on my article, I talked about 4 main categories of techniques. One is with a nitinol loop. We've mostly heard of the MyLoop, but there are other types of devices that are like that. They're a nitinol wire that we can insert into the eye and loop around the lens. And I think we'll be hearing more about that from Jeff and Deb. So I'll hold off on talking about that too much. Pre-choppers, which is another really fantastic and underrated tool to have. I was exposed to them personally during my fellowship with Brad Feldman at Wills. He used those all the time. And I really think that they're really valuable, not just for these dense lenses, but even for patients with immature gummy lenses that you really have a hard time separating and cracking. A pre-chopper like the Akahoshi or some of the other ones are just fantastic because they spread that surface area of the instrument along the length of the cataract. And so even in soft lenses, they can really applanate nicely and get a nice crack in the lens. And I think we're going to have some talk about that later on too. So I'll hold off going into detail. But the other ones, the other two, the modified chopping techniques and femtosecond laser, I do want to touch on and get your thoughts on it too. With femtosecond laser, I've not had a ton of experience, but the experience that I've had with it is that, it can make the capsulotomy, sure, but with really advanced cataracts, part of the issue is the brunescent nature of the cataracts, and getting a laser through a brunescent lens is pretty difficult. And for me, I know the hardest part about cracking a lens is getting through that posterior plate, right at the back of the cataract. That tends to be where the laser can't get to, and the most important part for us. So from a effectiveness standpoint, I haven't found it to be super effective. There are some clinical trials that I mentioned in the article that looked at femtosecond versus simply just phaco. They did find that femtosecond laser did decrease the total CDE, but unfortunately, they didn't find that there was clinical relevance there. So the patients didn't have any better outcome because of that femtosecond laser. So gonna wonder what your thoughts are that, but I also want to talk about some modified chopping techniques. There's a dime a dozen of them. For me, I'm a vertical chopper. I do that for most of my cases, and I modified a technique where you can drill some holes with the phaco tip into the lens in multiple places, kind of like in a circular fashion, before doing any cracking. And then when you're ready to crack, the initial pilot holes that you create in the cataract, you can place your chopper into that and get the chopper super far into the endonucleus and crack it much easier. We coined that rotary chop just because the image of that, multiple holes drilled into the endonucleus kind of looks like a rotary phone dial. But it's been really helpful for me to get really far posterior to that posterior plate and crack through it. So I'm curious to hear your thoughts on different chop techniques and femtosecond laser use. What do you all think about? We'll touch on femtosecond laser first. Do you use it for these dense cataracts? Do you sort of forego it for similar reasons or different reasons?
Christos, I used femtosecond for about 2 years. And, really, I think it's a wonderful technology and there's so many different uses for it. It's effective for maybe someone who has a posterior polar cataract because, you're worried about that capsule behind that cataract. And so I found that it can be maybe effective for that. Or in cases like pseudoexfoliation, if they dilate well enough, you don't want to manipulate that cataract. And so that can really decrease the energy. But all in all, I found that with new phacoemulsification technology and fluidics, our CDE has gone down dramatically just from stability of that. And so I have gone away from femtosecond and just do manual phaco.
Yeah. Femto, I love what you said, Deb, and it's really interesting. It came on with so much potential promise, and it still is really as far as technology goes. Sometimes when patients bring it up, their eyes just light up. Like voracious. They can't wait to have a laser inside of their eye. And just over time, we've all learned, okay, well, what is the real benefit to this? How much benefit is there versus cost to the patients? To a patient in Park City coming in versus a patient in another setting, that's a totally different value proposition. And when they do hear it advertised as like the latest greatest laser, I want the laser coming in. We certainly offer it to our patients. But again, as far as benefit for nuclear disassembly, there was some potential promise of it being used for dense nuclei. And it really seems over time that potential avenue or indication has not so much fallen by the wayside, but it hasn't really come to fruition where you're seeing wide adoption of dense nuclei and being femtofragmentation being a primary pathway.
Yeah, those are excellent points. And I was, Jeff, I was surprised too at the most recent ACOS meeting in Deer Valley, near Park City. We were discussing this with dense cataracts, and I was pretty impressed. There were a good amount of folks in the audience who still use femtosecond laser for dense cataracts, and I'm thinking, I wonder if I'm just not using the pattern correctly or whatever. But as you mentioned, there's an added cost to it. And as Deb mentioned, there's just fantastic options for phaco, and the technology continues to improve from a effectiveness standpoint, and not needing to really use too much CDE. So I'm in that same camp where even if it was shown to be decently effective of segmenting the lens, phaco technology is just so powerful these days. The cost ratio is not super high for me. So great. And then in terms of just modified phaco chop techniques, I know some of you chatted about or described that in the articles, but are there some go-to ones for you that you want to touch on?
So I feel like my technique continues to evolve because I find what's, in my population the best. And in Minnesota, we have Scandinavians, blonde hair, blue eyed pseudoexfoliation patients. And so I've found over time that in our area, patients may not dilate as well because of pseudoex. They're worried about zonular support. A lot of patients are on Flomax, with poor dilation, and we have good old farmers who come in with denser cataracts. And so I've kind of modified my divide and conquer technique. So I don't know. I was thinking about all these cool names because Christos, you've come up with all these beautiful coined cataract terms. And so maybe like the groovy chop, where I'm grooving in the center, dividing the nucleus, and then I'm chopping after that. So I really don't like to rotate the cataract. I like to make sure I get a good fluid wave under that cataract, so I know that it's going to be free. And then I make a nice groove in the center. I divide it with my Sinskey hook, and then I actually do a side swipe. So I actually take my phaco and I go to the side and then chop that into quadrants. And those quadrants are removed, and then the heminucleus is taken out and chopped from there. And so I've kind of taken all these techniques, and I find that it works really well for those gummy cataracts. I feel like it works well for small pupils, pseudoexfoliation, for patients that maybe you can't see far out into the periphery to get that nice vertical chop. Christos, I love your rotary technique. I think it is brilliant for dense cataracts. And I remember texting you being like, oh my goodness, this is so helpful, because it really does help you get down to that posterior plate. And so that's been such a helpful technique, for those dense cataracts.
Yeah, well, thanks for saying that. And actually, for those who want to check out your technique, in the article that you wrote, there's a QR code where you can watch your technique on iTube. So I thought that was really slick to be able to phaco sideways as well. Well, let's transition actually, since Jeff, you talk a lot about some cool techniques and technology. So in your article, you really highlighted the adoption of new techniques that can minimize phaco energy, what we call the cumulative dissipated energy, or CDE. And so, can you talk a little bit about a couple of the things that you use on your day-to-day for tackling these dense cataracts?
Yeah. I love what you said, Deb, and actually, I think non-rotational phaco techniques, it's pretty fundamentally important, and everyone should have a go-to technique that for 85% of lenses, in the case where you think, boy, could there be zonular weakness, that you don't rotate. We do so much damage and traumatize zonules. And really rotation is in a lot of experts' estimation the step that we're doing the most damage. All right, so Christos, I love the question. I think harkening back to some things that Tom Oding have said, you really do want to have a technique for soft lenses, right? Those really annoyingly soft lenses that can somehow be more difficult to take out than your 4 plus. And then, your 2 plus, 3 plus, and then your 4 plus. And there really isn't a perfect technique that spans all of them. Although the chop techniques, you can use those in a wide variety. You can certainly use divide and conquer techniques in a wide variety, but in those, 3, 4 plus, you're just burying, the endothelium with a lot of energy. So I'm going to start just talking about two things. One in detail, second one a little, ask you guys your opinions on. So non-phaco disassembly, so pre-chopping. So for those of you, listening, driving, wherever you are, well, if you haven't seen a pre-chopper, what is this? Imagine taking, you've got this beautiful birthday cake sitting on your desk, and it's a 9-inch birthday cake. You got to divide this thing in half. So you take 2 spatulas, one your right and one your left. You put the spatulas together and you just push that right down in the middle from the top to the bottom, and then you just separate with these paddles, and you separate that cake right in the middle, and that is pre-chopping. And for your 1 to 2 plus, run of the mill, 20, 30, 20, 40 cataract, your average person coming in at the right time for cataract surgery, pre-chopping is the beautiful, elegant, single-handed technique. I love it with residents early on before they're comfortable with a left hand in the eye and a right hand in the eye. You can divide the nucleus, rotate the nucleus manually with either the pre-chopper or with a second instrument of choice. Divide the nucleus. Again, it's in hemisections before you've used any phaco energy. And one nice, side effect of using these paddles are this cleaves really cleanly. Sometimes with divide and conquer, with chop, you can get these kind of interdigitating, pieces, a little bit almost like a jigsaw puzzle on some level. And these are just clean walls, and it makes removal of these quadrants really nice and easy. Again, there's a QR code in the article. You can see this. These instruments are not particularly expensive either, but it's a nice, really go-to technique, particularly perhaps you're part of your career where you want to try a different technique, or maybe you're not loving, your two-handed techniques for your run-of-the-mill cataract. This is a lovely technique to go to, a lovely technique to start teaching. Kind of let either of you comment on it, and I know we all have some thoughts on the other manual disassembly technique, phaco sparing the MyLoop.
Yeah, I'll mention that I was blown away when I first saw Brad using these during fellowship. It was just so elegant to see. I mean, you said it perfectly. The splitting of the cake. I think they kind of look like kitchen shears or like large tailor shears, where you could stick them into the cataract with that sharp point, and then it just breaks apart so cleanly, as you mentioned. So for me, I think now that I'm transitioning to especially some softer cataracts here compared to what I was seeing at the county hospital, I think I'll be adopting that instrument a lot more.
I think it is such a neat technique, and I had the opportunity to use it in residency. And Jeff, you are exactly right. Before we were really comfortable using both hands, or, say me, I'm a left-handed surgeon. And so all my attendings were right-handed. And so that became a little tricky with learning too. But it also made me more ambidextrous. But using this Akahashi was so slick because we really understood how to make that groove and how far to go into the nucleus when using that second instrument. So I think you're exactly right with training. It's so helpful. And then, like Christos mentioned, with softer cataracts, it breaks up really, really nicely.
Yeah, that's great. Well, let's chat about the other technology that we actually all talk about in our articles, which is the MyLoop. Again, it's not the only device that's on the market, but it's the most widely available. And so, just to describe how it works, and then we'll have you chat about where you like to use it. But it is a device where you slide into the eye, and you can extend a loop out from a small tube. It's made of nitinol, and it's heat treated to have a memory that's basically the shape of the cataract. You can expand it underneath the capsule, and then wrap it around the lens posteriorly, and you can actually visualize it in clear enough cataracts. Watch the nitinol loop going behind the cataract, and then contract the little plunger, and you basically tighten the noose of nitinol around the cataract, and it cuts right through the cataract super nicely. Dense cataracts, soft cataracts, it's pretty impressive to watch. So, when do you typically tend to use it? Do you use it on routine cases too? And do you have any tips or tricks for the audience who might want to adopt it?
Christos, I started using it in preparation for global ophthalmology because I wanted to have another technique to be able to maybe not do M6, but be able to remove some of these denser cataracts in a minimally invasive way. And so one trick is to start using it in your routine patients, because I found that being able to really follow that nitinol loop all the way around the posterior plate, actually over rotate, and then come back and cut the nucleus in half was really, really helpful, because when you start with a white cataract or a dense cataract with no red reflex, and you've never done it before, it's really hard to visualize what it's doing posteriorly. And so that's one thing that I would recommend for people is to do at least 10 routine cases and to really get that technique down. The second reason of doing that is because a lot of our denser cataracts are going to have weak zonules. And so you want to understand how it stretches. And so you can either stop if you need to, if you see any zonular weakness, or to really understand how that nitinol ring is expanding in the eye and be okay with continuing.
Great points. I just, I love what you're saying, and paying attention to zonule is so important. If I was designing an instrument that could help me, push an entire lens into the vitreous, it might look something like the MyLoop. Now, it doesn't, but you really need to have a low threshold for just backing off, because you are putting in a paddle that is then rotating behind, and so you've really got 180 degrees of pressure or force, downward. And if you've got loose zonules, it can, make a hard case, a now combined case with retina. So the other thing I really recommend, so when you first get your MyLoop out, before you go into the eye, extend it all the way and then put it on the cornea and mentally visualize where that centers. The anterior segment anatomy varies, the white to white varies, and if you rely on pushing it all the way to that hub or plunger, a majority of the time you're actually going to be pushing it too far distal and actually, potentially worsening zonulopathy. So just make that mental note. As I open this, sitting on the cornea before I've gone in the eye, where is the center? Where is that hub, that proximal hub they have? Where should that be relative to the limbus? And then remember that as you're inserting it, and that'll save you a lot of distal zonulopathy. And there have been bag breaks with this by people just pushing too far in, relying on that hub to stop them.
Yeah, that's a great point. I mean, it's if not done correctly, I mean, it could be an intracap too. But like anything, we didn't find, it's not like the phaco and the stone, right? Where we pulled this phaco handle out of a stone and just started using it, and it was glorious. It took, we need to do 86 cases of those before somebody says you can do this even on your own. And so I think we need to give a little bit more leeway to devices, not just jumping into complex cataracts, as Deb said, or just giving it the respect it needs to really understand the anatomy, how the device works. You should not go into any of these new devices thinking I can do one and I'm ready to go. So there's definitely a learning curve, but I found it to be quite easy. The other thing I really like that Deb kind of touched on is it actually is one of the few things that cuts from the outside in. If you think about it, it brings everything towards the center. And whereas we're really trying to crack by pushing against the bag, if you think about it, this, once it's in place, is bringing everything towards the center, which is kind of novel in itself. So, but looking forward to seeing how it plays out more. It's now device that Zeiss owns. And so I think from a distribution standpoint, it's going to be more widely available. And curious to hear what surgeons out there listening have to say about it. So please reach out and give us some feedback on it. So let's jump over to Deb, your article. I really liked how you highlighted the value of pre-planning. You can save yourself so much grief if you just pre-plan, understand the different algorithms that you're going to go down depending on what happens, and just being ready to change course, and what's best for a given situation. So tell us about your go-to technique for really dense cataracts. I know you talk about the manual small incision cataract surgery technique. You're talking to two huge fans here. Both Jeff and I love to do this surgery. And so can you talk a bit about your surgical planning for that and what you tend to do?
I love to make notes. Before I go into surgery, I have the IOL master chalked up with notes, whether they're on Flomax, whether they're a pore dilator, whether they have pseudoexfoliation, if they've had trauma, the density of the lens, anything that, I'm catching on examination that could change course. And so I actually have things right out for us, because what happens when we have a complication? You need it now. And so having things that are readily available, capsular tension rings and trypan blue and more viscoelastic and a 3-piece IOL with a different cartridge, anything that you think you would need if, things don't go the way that you planned. Or say you have to convert to M6, where you think you can phaco and you're just having a really difficult time. And Christos and Jeff, tonight you mentioned how you just really damage the endothelial cells. When you get in there and you're doing divide and conquer and you're trying to really get through this cataract, sometimes maybe it's good to just stop and either transition to MyLoop, which you can do. There's enough thickness there where you can transition to MyLoop, or you can convert to M6. And for those of you who haven't done global work or have been on a missions trip, I would definitely encourage you to go. These people don't have care. They need our help. They're blind. And a lot of times they're not working and providing for their families. And so I'm really passionate about that. And, I remember my grandpa talking about, as a general surgeon, how he started doing cataract surgery. And it was basically people from the village coming to him saying, is there anything that you can do for my dad? They would lead him in. He couldn't see. He wasn't working. He wasn't providing. And so he literally ordered a how-to book on how to take out a cataract and started doing cataract surgery. And that really changed the course of his, story. And so I always think back to that on, here's a general ophthalmologist in the bush learning how to do cataract surgery. And it's just amazing, the opportunities, that we have globally to serve. So with M6, manual small incision cataract surgery, a lot of us aren't very comfortable coming out of residency doing this technique. But I tell you, I do it in the United States. When you see a really dark, nasty looking cataract, phacoemulsification is going to be tough. And so being able to have a technique where you make a nice scleral tunnel, where you're able to take out that cataract fully, and to do it without having to suture the wound, the next day their cornea looks pristine. And they're seeing and they're so excited jumping out of the chair, because these cataracts are ones where they haven't seen for a long time, right? And so to have this technique in your back pocket, to be able to convert to it, it really does decrease some of the complications that can occur down the road or at the time of surgery.
Yeah, those are great points. And I think we could all agree those are some of our favorite patients when we see them the next day. And it's really a lot of times about lines gained, and you can't get patients with more of a vision recovery than those who are coming in hand motion or light perception. As you said, the corneas could be crystal clear the next day. No sutures necessary, minimal astigmatism if you know how to do the wound. in such a way, and they could be 20/20 the next day. So it's really, I think it takes education to highlight how good of a surgery it is, because yes, we could all phaco anything if we try hard enough, but it might not be what's best for that patient in that situation. So, Jeff, what do you think? Any pearls?
Great points. If you haven't done any form of manual delivery of the nucleus, either whether that's M6, ECI, and that's at least for 10 years of ophthalmology trainees that we've really gone away from having this manual form of delivery. Uh, Best practices. This is not just like a simple modification of a nucleus chop, that you're used to. This is a pretty significant excursion from what you've done if you've only done clear corneal cataract excisions. If you have scleral tunnel experience, you're in glaucoma, you're going to have a little easier time getting to it. But best practices are the following: one, watch a lot of videos, read a lot of books, do some wet lab with some experienced people, but you can't really do this in the best manner for your patients without having someone really experienced sit with you and help teach you. You can learn it on your own, and you will have more complications along the way if you're doing this on your own, versus getting someone who can anticipate what you're about to do, prevent the complications, show you how to address it before it ever happens. It's like I said several times. I could go back and start learning how to do squint surgery, strabismus surgery. I'd get it, but I'd leave a whole lot of crossed eyes in my wake that I wouldn't want to look back and see.
Yeah, those are great points. I mean, if you really think about it, there are only maybe one step, which is hydrodissection, that might be similar to phacoemulsification standard surgery that we know. And even then, usually we're trying to pop the lens out of the bag, which not most phacosurgeons tend to try and keep it in the bag. And so every other step is different. And not all cataract surgery is just cataract surgery, right? It's not um, similar in really any respect. And so, as you mentioned, really getting that experience, sitting with somebody, doing the wet labs, just like with phacoemulsification, this is, just as difficult. And studies show that in the hands of trainees, there can be more complications simply because these are not routine cases. They're more mature cataracts. Zonulopathy can be frequent. And so really setting yourself up for success. And really going back to what Deb said, I cannot tell you um, how much you can decrease anxiety levels and feel really confident when you just map everything out. You draw out the case, you think about what could happen, you draw that out. Uh, you just sort of have a game plan. Um, there's nothing you haven't thought about, and that way you stay cool as a cucumber in the OR, and that's what allows you to have clear decision making. So, super important. So, I guess what I'm hearing here is that there's no one answer to these cases, no single best way to crack the nucleus. I'm happy that we covered so many different techniques here, based on the different types of settings you're in, the resources you have. And most of all, hopefully the audience has heard a couple of new things that they're willing to try out. If you need to learn more or want to learn more, you can check out the articles that we wrote. It's the cover story of the CRST October issue at crstoday.com. Doctors Petty and Risbet, do you have any last comments before we sign off?
I just want to thank CRST again for allowing us to do this nice podcast. And Christos, it's always an honor to talk to you and learn from you. And I will continue to be in awe of the techniques that you're coming up with and all that you do.
And bravo, CRST. This is excellent. Love podcasts. I wish you guys could see the image. Deb is just vibrant there with great smiles, sitting next to this beautiful art of looks like a Montana lake in the mountains, and then you've got Christos, who's bookended by the psychedelic squid and that beaker from the Muppets. It really is an honor. Do yourselves a favor, like take a half day and go watch anyone else in the operating room. It is such time well spent. And if you aren't in a larger center where you could do that easily, you will always pick up things and learn things from people as you watch them operate. And particularly if you're out in private practice, solo practice, only a couple of you, that is time well spent. And we should continue to improve our surgery every year and never stagnate. If you're doing the same surgery you did, when you left residency, then it's time to get out and learn from someone else and improve your techniques.
Yeah. Well, thanks to both of you. I mean, a lot of wisdom shared here. I've learned so much in this short amount of time, and Deb, the feeling is very mutual with both of you all. I am super honored to be on here with both of you, and thanks again to CRST for joining, and for everybody else for joining us tonight. And hope to hear feedback from you trying out these new techniques. Take care.
For more shows like the one you just listened to, check out the podcast channel on itube.net.